Obesity is defined as being body mass index greater than 30. Morbid obesity is defined as being body mass index 40. This definition is more accepted internationally and has essentially replaced the former one for all practical and scientific purposes. It is suggested that the term severe obesity is more appropriate for defining people of such size. It is estimated that more than one-third of US adults' population is obese, and prevalence of obesity in adolescents is 17. The percentage of obesity in the United States increased 16 percentage points from 1980 to 2000, and the prevalence of morbidly obese adults has increased to 6% of adult population in 2010. The surgical treatment of morbid obesity is known as bariatric surgery. Its origins in the 1950s, when malabsorptive operations were first performed for severe hyperlipidemia syndromes. Until very recently, obesity was not recognized as a disease, which confounded the ability of physicians to be compensated for treatment they delivered and to treat the condition effectively. The American Medical Association officially recognized obesity as a disease in 2013. Morbid obesity is the second leading cause of preventable death in the United States and is second only to smoking on the list of preventable factors responsible for increased healthcare costs. It's a sobering thought to realize that a 25-year-old morbidly obese man has a 32% reduction in life expectancy and 12 years of life lost compared with a normal-sized man. Morbid obesity is a metabolic disease associated with numerous medical problems, some of which are virtually unknown in the absence of obesity. Morbid obesity is associated with many important systemic diseases such as hypertension, sudden cardiac death, cardiomyopathy, deep venous thrombosis, pulmonary hypertension, obstructive sleep apnea, hypoventilation syndrome, metabolic syndrome, type 2 diabetes, hyperlipidemia, hypercholesterolemia, gastroesophageal reflux disease, cholelithiasis, lumbar disc hernia, osteoarthritis, stress urinary incontinence, end-stage renal diseases, menstrual irregularities, fungal infections, pseudotumor cerebri, depression, and many social and psychological problems. The main factor affecting a person's being obese are genetics, environmental, and personal preferences. When our body weight and fat level fall below the threshold value, our body activates defense mechanisms to protect its weight and fat. Dr. David Katz, founding director of Yale University, says, "For most human history, it was difficult to find calorie defense foods and eat calories. So we have developed numerous defense mechanisms against the risk of starvation, but we have no defense mechanism against overeating." The brain of an obese person who is on a diet thinks that the body is in the state of hunger and activates its protection mechanisms. This makes weight loss very difficult. According to an important Swedish study, a 19 kg patient can achieve a permanent weight loss only 1.8 kg after 20 years. With grueling weight loss programs, 95% of obese people return to their old weight within 2 to 5 years. Obesity affects most of the organs. The higher a patient's BMI, and it is the higher the risk of obesity-related diseases. As the level of obesity progresses, the recommended treatment options are also changed. Lifestyle changes are usually the first treatment options. This option includes diet, physical activity, and behavior changes. The further option is drug therapy. In the presence of type 2 diabetes mellitus, insulin can be also used. Gastric Botox injections can be very helpful to make low-caloric diet sustainable. It is not a complicated procedure. After sedative medications, it can be performed endoscopically within 10 minutes. Also, intragastric balloon is a good method for losing weight. It's performed endoscopically or can be swallowed. The person whose BMI is higher than 35 with secondary diseases or 40 with or without secondary diseases can be cured with surgery according to the American health community. Medical therapy for severe obesity has limited short-term success and almost non-existent long-term success. Once severely obese, the likelihood that a person will lose enough weight by dietary means diabetes alone and remain at BMI below 35 is estimated 3% or less. According to the consensus published by the American Health Association in 2005, surgery is the only option for permanent weight loss. Bariatric and metabolic surgery shows significant improvements up to 75% in obesity-related diseases like type 2 diabetes, hypertension, osteoporosis, joint diseases, sleep apnea, and the others. Bariatric surgery provides us substantial weight loss compared with lifestyle change or drug therapy. It provides more than 45% weight loss in the 3 years after postoperative period. In a 10-year average, bariatric surgery leads to 20 kg loss, while in other options lead only 1 kg loss. For an obese person to lose weight significantly and permanently, his or her body's balance system needs to be rebuilt. Thus, his body's storage of excess fat can be stopped. The most effective method to achieve is surgery. At the same time, it was observed that 80% of the patients also disappeared from obesity-related diseases. Bariatric and metabolic surgery provides weight loss by unraveling the complex relationship between food and metabolism. Thanks to bariatric and metabolic surgery, it has been observed that value for fats in the body is lowered. With bariatric and metabolic surgery, the anatomy of the stomach and small intestine is changed. As a result of hormonal changes without your effort, appetite decreases and the feeling of satiety increases. Perhaps more importantly, results after bariatric surgery, it increases the comfort of the life. Patients must have some criteria for consideration for bariatric surgery, like having a BMI 40 or having a BMI 35 with an associated medical comorbidities or worsening by obesity. Failed dietary therapy is one indication of surgery. Psychologically stable without alcohol dependence or illegal drug use is very important for us to choose the candidate for surgery. The patient must be very well motivated. Medical problems not precluding probable survival from surgery is a contraindication for obesity surgery. We divide the surgery options into 3 groups. Restrictive procedures like sleeve gastrectomy, malabsorptive procedures like biliopancreatic diversion, and both restrictive and malabsorptive procedures like bypass procedures. We decide which procedure will be performed depending on the patient's comorbidities, patient characteristics, and plan the treatment individually. Bariatric surgery is not more dangerous from any other surgeries. Of course, it has complication risks like leakage, hemorrhage, and others. But this risk also acceptable for all digestive system surgeries. The major complication risks like hemorrhage, leakage, pulmonary embolia rates are lower than 1%. We have solutions for these complications. The procedures have nearly 1 per 1,000 mortality in series. It's not a big number for an abdominal surgery. We know a morbidly obese person has 12 or 15 years shorter life expectancy compared to a normal weight person. It is not only shorter, it's an unhealthy, uncomfortable, and a difficult life. It has also psychological and social problems. Even we cannot imagine some of them. Obesity makes higher cancer risk, diabetes, and a lot of diseases. In the light of all we learned, surgery is not more dangerous from being a morbid obese.